everyone. If I can just ask everyone to make sure that they are on mute, that would be wonderful. We're speaking to you just before Remembrance Day, so it would seem appropriate to thank all of those. Particularly, Warwickshire has a fine history with the Royal Warwickshire Regiment of service in the military and elsewhere, and I know a number of governors are involved with the British Legion, and a number of families within Warwickshire have loved ones who have served in different parts of our armed forces. So I'd just like to thank them for their service and for what it means, particularly for our country. And given all of the turbulence that's going on in the world, which we'll all see in the news, it's important to remember our history. In terms of apologies for absence, Sarah, can you read out the apologies, please?
Thank you, Russell. So we've got apologies from Graham Nuttall, Liz Cole, John Holland, Jim Sinnott, Parmjit Gill, Phil Gilbert, Fiona Burton, and Sue Warner is going to join us about 30 minutes late. Thank you.
Okay. Thank you very much, Sarah. Any declarations of qualification for office or declarations of interest? Could you please raise a digital hand? Okay, so we'll take those as accurate as previously provided. The minutes of the meeting held on the 21st of September. If you have any amendments to those, could you please raise a digital hand for me, please? Thank you, Sarah, for doing that. Okay, so I'll take those as accurate. Then the action points arising, which are on page 22 of the pack. The first was with respect to the patient experience assurance report. That was a request to identify other. Within that, that was completed. Thank you, Fiona, in absence. The clinical governance assurance report. The pharmacy service update, which is on the agenda, will cover that. So thank you in advance, Samara. Then the patient safety surveillance committee update. That training session is scheduled, was scheduled for today, but I think it may have been rearranged. Are there any other matters arising that colleagues feel I've missed? Could you please raise a digital hand? Okay, thank you. So on this point of the agenda, it's Michael, could I ask you to make sure you stay on mute, because when you come off, it causes enormous feedback. Just a very quick overview from me, and an overview really focused on thanks. Glenn will cover it off a bit later, but we have been unbelievably busy as a trust over the last 3 months. In particular, the level of attendances into our A&D department have been quite extraordinary, and I want to thank all of our frontline teams, but particularly Harkamel for her oversight and juggling of all the different challenges we've had, and with Adam's help and the rest of the team's input, we've been able to ensure that, certainly compared to other parts of the NHS, patients in South Warwickshire and their families have been seen generally much faster than they would have been elsewhere. So enormous thanks to them. I'd also like to thank more generally all of our teams with the challenges as winter approaches. We always know winter is a challenge. This year is going to be particularly tough, and again, we'll take on board some of that. And finally, I'd just like to thank Glenn Burley, our Chief Executive, because since the last Council of Governors, Glenn and I have taken over as Chair and Chief Executive of Worcestershire Acute, which has placed extra challenges on Glenn. But despite that, he continues to ensure that the people of Warwickshire receive the healthcare that they would like. So enormous thanks for them. Things are going to be very tough over the next few months. And the Trust have started a campaign around Home is Best. The evidence for hospital-acquired functional decline, both physically and emotionally, if you stay too long in hospital is really clear as a body of evidence. So we are promoting, and we'd like members of the public to help us in this regard, that if you're ready to go home and the clinical advice is to go home, the best place is to be at home, to be mobile, to be self-sufficient. So we will be having quite a campaign on this around home is best across all of the foundation group, and particularly across Swift over the next few months. So without further ado, we'll move on then to some assurance items. And the first is a pharmacy service update from Samara. So Samara, over to you.
Russell, I don't think she's actually joined us yet. Do you want to take Harkamal's item? Because Harkamal's with us and I'll contact Samara.
That would be great, thank you. Unfortunately, I'm a chair who likes people to be better an hour early than a minute late, but thank you if you could do that, Sarah. So Harkamal, could you brief us then, please, on the consequences of industrial action and the trust's mitigations?
Yes, thank you very much for having me. So I'm sharing my screen, so I trust that everyone can see that.
Yes, we can.
Fab. So for everybody's benefit, we've had a number of strikes. I'm sure you're all aware from the news this year. We've had during 2023, we've had 7 sets of junior doctor strikes totaling 21 days and 4 sets of consultant strikes totaling 9 days. And we've had 4 days which were joint consultants and junior doctors, which was quite unprecedented, I'd say, in the NHS. So we've managed to get through that. And at the moment, we don't, as you'll know, have anything else on the horizon. I've detailed in here, but I won't go through it in detail, just the proportion of doctors that were on strike for each set of industrial action. For junior doctors, the lowest was 61% on the 15th of June, but that was part of a wider 5-day strike. And the highest was 91% of junior doctors on strike in August, and that was part of a 4-day strike. When we go then to look at the consultant strikes, we had around, the figures were around the same for all of the strikes, but the lowest was 16% and the highest was 27% in September. When we go then to look at the joint strikes, we had around 20% of our consultants on strike and 48% of our junior doctors on strike on the same day. So in terms of our approach to managing these strikes, I would say that we have a really strong approach to planning, and our resilience certainly shows through. We have established bronze meetings 3 times a day and then more during operational pressures. And we run a daily Silver Command meeting, which the execs attend with open invitation to the trust to talk about what's going on that day and provide the support necessary. And because that structure works so well for us, we just basically expand that during a period of strike. So we put in an additional pre-strike silver, where every day we get together to hear divisional updates and divisional planning for how we're going to approach the strike. And then during the strike, we run our usual silvers, where we talk about any exceptions, but then have a meeting at the end of the day just to go through what's happened and if there's any further support required. I've put some detail around what that pre-strike planning looks like, and I don't propose to go through it in detail. But what I would say is strike planning almost became business as usual, which is a really surreal statement, I think, to make to this group. And also, just when I was preparing for this presentation, just reflecting on that, I don't think I ever would have said anything sort of like that. And actually, what it sort of turned into was the divisions managing really well themselves. So our pre-strike meetings ended up being quite short, and it was just a call for help or a check that we're being consistent across the trust or any other thorny issues that sort of might have come up. But as we got into the rhythm of pre-strike planning, those meetings certainly got a lot shorter, and actually much of the business took place within the divisions. We also tried to take an approach of patient first, because you have to. So right at the beginning of the strikes, when they first began, we tried everything that we could to try and avoid any cancellation of patients. As you all know, that's a value that we all hold strong and stand firm in. But what we did learn is that actually that has cancelling patients at the last minute is really distressing, and it's a lot of admin. So to get that right and to do it in the way that we would like, became more challenging when we became more au fait with the strikes and had a better understanding of how many staff we were going to be without on those days. So we changed our approach slightly and became more proactive. So doing more proactive list planning and really understanding what that picture looked like, and didn't book as proactively during the strikes and focused our attention on where we thought it might be needed. I've got to say that without our volunteers and without our very flexible teams acting up and down, none of this would have been possible. The resilience and the willingness of everyone to go absolutely above and beyond, I don't think we could have got through it without. And so a special thank you to our volunteers and to our bookers. I would say that of everyone, the bookers had a disproportionate amount of effect on their day-to-day role. I think they found it very, very hard to be in contact with patients who they may have just booked the day before to then cancel them or reschedule them. And understandably, they got quite a lot of concern and angst from our patients who wanted to know when they were going to be rebooked. So the average call length increased significantly. The level of distress that these patients were facing, and then asking for reassurance from our bookers, obviously took quite a toll on our staff. So that was certainly learning very early on. And during the strikes, we made sure to really proactively do the wellbeing checks on all parts of the organisation. Certainly with things like strikes, issues can kind of pop up anywhere. And it's really important to be agile and responsive in the face of whatever issues we might face. During the strikes, we expanded upon our silver meetings, so we just made sure that there was maximum exec visibility. So should anyone need support, we were all on hand to pop down or go wherever was sort of needed to provide that. In terms of the overall impact, I've detailed the numbers there, but it is 135 admissions that were cancelled, 600 outpatient new appointments, I should say, and 850 follow-up appointments. We did cancel some diagnostics within that, and I haven't pulled that out. And some of those outpatient follow-ups did have procedures within them. Following the strikes, we did a lot of work on learning and reflecting, and I think that's how we ended up getting to a point where strike planning was business as usual. We made a really big effort to do a lot of hot debriefs, a lot of rapid learning events to make sure that we were capturing anything that was coming up so that we could proactively plan for it the next time around. And we held a number of roundtables to understand what went well. And actually, we've taken quite a lot of that into our winter planning. And certainly the roundtables really helped us, and it provided the opportunity for everybody to give an insight into what worked for them. And certainly a lot of that was around the communication. In terms of what impact that had on the organisation financially, I put a table in the presentation that I'm sharing now to map out what that overall impact looked like. So we estimate that we lost £851,000 worth of income. And the reason I've used the word estimate is because a number of those patients weren't scheduled in the first place, because we wanted to avoid having to cancel them at very short notice. So that is significant. Clearly, the impact on cancelling patients is not where you want to be in terms of managing some of your long waiters. But I just wanted to provide assurance that although our waiting list increased, our proportion of patients waiting over 52 weeks decreased. So at the beginning of the year, we had 7,385 patients waiting over 52 weeks. And as of the 3rd of November, we have 3,737, which is a 50% reduction in our overall long waiting position. So overall, I can't underestimate or understate just how challenging it is to manage strikes. It's really upsetting. Nobody does it willingly. Planning for it is difficult. Operational pressures have been significant over the summer. But the focus of the staff to continue to try and provide an excellent service, the willingness of everybody to be flexible and just go where is needed, even if that means working outside of scope or needing extra support or additional floor walkers to support with IT, additional pharmacists to make sure that all those bits are sped up. are really the bits that got us through. And I'm really proud that we didn't take the eye off the ball with the long waiters. I know that nationally, and locally here, we're trying really hard to focus on making sure we don't have any patients waiting over 104 weeks as an absolute, or 78 weeks. We're working on 64 weeks, but I feel it's really important also to think about the 52 weeks, and that's why I shared that 50% reduction, because if we can keep focusing on that, that will inevitably just help us further down the line. And 52 weeks is a year, so it's still a very long time to wait for treatment. And I'm really pleased that despite all of the rescheduling and all of the work that we've had to undertake, we haven't taken the focus off that. So we can still say that we are absolutely going in the right direction.
Kamal, very comprehensive. Thank you very much. And as I said, thank you for your energy. Just two things I'd like to add. The first is an apology again to patients and their families where we had to change arrangements. We know it's very stressful being on a waiting list. We know the process of planning to come into hospital is stressful in itself. But I think, as you have heard from Kamal, we've done absolutely everything we possibly could to minimise the impact. But when it has had an impact on you, I apologise on behalf of the Trust. The second is a vote of thanks. I really do appreciate the seriousness with which colleagues who are taking industrial action feel regarding the fairness or unfairness of the situation they find themselves in. But in terms of our primary concern, which is the well-being of our citizens, for those members of our teams who have worked through strike action, I'd like to say a particular thanks, because we know that's a difficult personal decision, but it does have a real impact on how we're able to look after the citizens that we serve. Can I ask Governor colleagues, given the broad agenda we've got today, to pop questions or perspectives into the chat box, and then we'll take those as we go along. But thank you, Kamal. We'll move then back to the pharmacy services update. Samara, welcome. Samara, you've got 10 minutes. Over to you.
Thank you. I was going to read the paper as read, and I was actually going to open the floor for conversations today. I wanted to have more of a conversation because I've met some of the governor colleagues offline as well, and attended some of the other meetings as well. So I wanted to give opportunity for people to really discuss and ask any questions that they had about the services. But what I've attempted to highlight here is a bit of a flavour of the kind of services we offer and the different team members that we have, some registrant and some non-registrants in our workforce, and the kind of services they are delivering. And the other thing I wanted to really focus on, because is the challenges that we've been facing almost through COVID period and now hitting into a post-COVID recovery period. Most of our team on the call today would have heard at some stage about aseptic service provision, the challenges we faced for a little while on there. The service is now fully staffed, but we obviously still continue to be fragile. The services are treated as fragile services at a system level and almost at a national level as well. So we are really recovering back out of ourselves as Swift out of that, but there is definitely national challenges and local challenges around the service provisions there as well. The positive for Swift is that we actually have brand new estate. Our estate is not that old, and we committed a lot of resource to that estate and our commitment to providing services to our colleagues in the foundation group as well. So that commitment still stands from Swift perspective. But the challenges we faced is the ageing workforce and people moving on for better opportunities for them, and that's what we're attempting to address with different kind of non-registrant career pathways, etc., that we're exploring now at Swift anyway. The other main challenge, I think, is what we call our registrant workforce. That is the team that is pharmacists and technician roles at junior levels, not at senior levels, at junior levels, who we felt through COVID have had a lot of opportunities open up around not really addressing the work-life balance. So we've had lots of people leaving to be independent, agency, etc. So some of that has been financial drivers that have come into play. Some of that has been personal, people kind of feeling the pressure and the burnout of working through the COVID period with us as well. And a lot of us are very aware of our primary care network roles opening. So all of a sudden there was an extra cohort of roles opened that there wasn't really national planning on how those roles would be filled. So those almost those individuals have come from our workforce as well. So I just wanted to again give some assurances around what work is happening currently, how the national picture is slightly changing. There, I think, will continue be tensions in the coming, I want to say, 3 to 5 years, because the national pharmacy training programs are changing. We are expecting new cohorts of students coming through, which will come with very different skill set in the coming few years as well. So we're already starting to plan for the impact of that new workforce coming through. And as part of that, the amount of training resource that's been put in place nationally, but at a local level as well, just to attempt to grow our own workforce where we can as well. So I won't say that we are in the best position in terms of our recruitment or retention. We seem to get a lot of applicants, but we're not seeing applicants then seeing it all the way through. So people are pulling out at the very last stages of interviews, etc. as well. But it's an ongoing piece of work that we are doing. And we're looking at different ways and models of working. We work really well with our foundation group colleagues as well. So the learning that some of the others have already faced, what they've been able to do differently, what we can learn from them. So there's a massive piece of work happening around there. But I think internally as well, I just wanted to again bring some assurance around the level of oversight and the level of input that's been put in across all tiers, I would say, around the trust as well, in terms of attempting to support some of our challenges. And we're looking at now widening our scope of what we considered. We started as more of a workforce focused group with exec sponsorship. We are extending that to look at the wider impact of the services we offer, and not just workforce, because the challenges are, quality will always suffer if we don't have the workforce. We're looking at the quality impact, we're looking at the workforce impact, we're looking at the operational impact as well, and trying to bring it all together and develop almost a strategy of what we'll be doing moving forward out of that as well. So I just wanted to again thank everyone, really. There's been lots of people on this call I know who've been heavily involved in supporting us as well through this time period. So I just wanted to say thank you to those people as well. And I'll stop at that, Russell, and I'll take any questions.
Okay, thank you, Samara. So we've got time for a couple of questions. Callie?
Yes, thanks, Parvez. I just have a question, obviously, because I'm not a pharmacist, something about TTO and discharge support. It says there is work underway to focus on measures that would allow reduction in the number of items required dispensing at the point of discharge, to include increase of label medication usage and one-stop dispensing. Can you explain a bit what that means? That's all, if you.
Okay. So in terms of supporting discharges, when our patients come in, the number of activity the pharmacy undertakes is irrespective of what happens clinically with the TTOs and discharges. We look at using patients on medication to reduce the wastage and making sure that they can take the medication it's fit for purpose when they go home. We also look at supplying medication while they're with us that they can actually use while they're inpatient, and then they can take home at the point of discharge. The medication is ready for them once we know they're going to be stable on their medication. That's what's called one-stop dispensing. So it's ready to discharge. It's not stock medication that people are using. So we are focusing back our energies on that, because what that allows us to do is almost have as much of the medication that a patient is stable on, that's not going to change at the point of discharge, in their lockers, ready at the point of the TTO being written. And sometimes we can complete those discharges on the ward then, because it just needs a clinical screen and the medication's already ready. So that stops the delays in discharges. During COVID, there was a period, again, that was nationally driven, where the focus was don't do one-stops because of the patient movement and COVID challenges around spreading the COVID and where the patients were going into homes, etc. That's now lifted. So as part of our reset, we are refocusing our efforts to make sure that we're picking those numbers up. So that's what I meant when we're saying that we're starting to do that work back up. And already I've seen the figures. I was reviewing the October figures. Slowly I can see the shift happening, less on TTOs, less on the inpatient, which is basically something they're just going to use on the ward and they can't take home for discharges, and more of the items they're ready for them to really take home from the moment a discharge is written or TTO is written.
Okay,
that's thank you.
Thank you, Cam. Just a quick question from me, Samara, then we'll need to move on. Obviously, you look after the George Eliot as well, pharmacy services, but when you look across the Midlands, pharmacy is obviously a very challenged service because of all the recruitment challenges and retention challenges you mentioned. Is there anywhere that is doing pharmacy better than Swift in your view?
I could be really biased here, Russell, but I would say we're doing really well at George Eliot, considering what we inherited and how we work in there. Our recruitment challenges are not the same. We did have the recruitment challenges. We had very little staff. We were very much run an agency there as well. So situation slightly shifted for us. And I think one of the questions Mary was asking me as well is, why is it better at George Eliot than it is at Swift? And a lot of that feels to us is around our location and where we're at, because we almost pull, George Eliot pulls a lot of local technical workforce, lives closer to George Eliot. And a lot of our workforce comes from mostly Leicester way as well. So we have, and UHCW do, okay for staffing for that reason as well. Our staffing mostly comes from Birmingham, and for them it just feels commute somehow becomes an issue, or people start with us and then they find the commute isn't what they signed up for, so they're not as interested in staying with us. And obviously Birmingham got their own challenges as well. There's not enough staff basically to go around, so they are running massively through their own deficit as well, so they're not necessarily doing any better than we are in terms of staffing at the moment.
Okay, that's great, Samara. Thank you very much for your hard work. Please take the message back to your teams about our gratefulness for everything they do day in, day out to allow patients to go home safely as quickly as possible. Take care. We'll move on.
Do. Thank you very much.
We'll move on then, colleagues, to the operational assurance and the quarterly status update report. Glenn, over to you.
Thank you, Russell. So this is the standard report that shows how we are progressing our objectives. Probably just go back to the item that Harkamal took you through a moment ago, just to put all of this in context with the operational pressures that people have been facing, because I think I actually joined quite a few of those silver command calls during strike days, and I do during some other busy days as well, and they're incredibly reassuring to me to see the competence and the coordination of the teams to ensure that we not only keep patients safe, but also try and keep as much of our work going as we possibly can. So they always make me feel better, even though I can see people working really hard on things. But alongside all of those operational pressures, we've lost a lot of management headroom, and you might have seen that reflecting in the progress against our objectives, but actually you're not. So I'm really pleased to take you through the headlines from this report, which show over quite a few pages all the other things that are going on alongside that, kind of keeping our patients safe, keeping our activity going through the organisation. And you'll see in some of those earlier objectives quite a big focus on our workforce, on inclusivity, on training and developing individuals. The staff survey, the national NHS staff survey is out there at the moment, and we've had a good response rate so far, and we will be looking carefully to see what our numbers look like when we see them later on in the year. And you always hear me say this, that's the most important indicator for us about how things are moving forward. So thanks to great work of Adam and the rest of the execs, you've got an update on all of the objectives here. Some of the big moves work around being a very flexible employer, and that's playing out in a number of areas, including some pilots around self-rostering. I think Samara just kind of emphasised the competition for staff members in the NHS and how important it is for us to be a good employer. So those pilots are hopefully demonstrating that putting teams in control to create that flexibility is a good way to recruit and retain and incentivise people. We've been doing inclusive mentoring. We've established a people board, and you can see a number of actions that are being tracked through that, including improving our time to hire. So from identifying the need to recruit an individual to actually getting them in the organisation, which has improved significantly. And in fact, our recruitment position is better. The other thing that's significantly better is the level of sickness in the organisation. And actually, we're a national outlier in terms of the 3.5% stat that we're quoting there. some of you attended the 4 boards session last week, where we do comparative information across all of the trusts in the group, and I think the highest in the group was 5.7%. So it's really good to see where we are with that. That's starting to show, obviously that improves our quality, etc., but it's starting to also show in our financials, and I'm sure Kim will talk a little bit. We need a bit more to come, but starting to reduce the number of agency and locum staff we would spend our money. And of course, the other thing that's made that quite hard to track has been the impact of the strikes, where we've needed to spend a little bit more than we planned to. We're developing a 5-year grow your own workforce plan. We also then turn to the discharge integration frontrunner work. So I think I shared that in a public board meeting also. What that is focusing on is one of our other big moves, which is around supporting the domiciliary care market. And that is resulting in many more patients going through what we call Pathway 1, which is patients going home with their discharge to assess support in their home with domiciliary care workers, but also our therapy staff. And that enhanced level of therapy is allowing more patients to go home first. So going back to the point you made at the start of the meeting, Russell, that emphasis on home being the best place for people to be and the better outcomes associated with that, but also achieving better flow. So we continue to be one of the best performing, certainly in the Midlands, organisations on A&E waiting times and ambulance handovers. And I'd probably say at that point, that is also, and I know governors are aware of this because you've heard me talk about it before, that better level of performance on urgent care is also leading to us being more popular with ambulances from elsewhere in the region, and also some walk-in patients from the edges of South Warwickshire. So in my 17 years here, I think when I first arrived, 150 A&E attendances was a busy day, and it's now 350 A&E attendances are a busy day. So that shows the level of increase. We're also in that particular work, the integration frontrunner work, moving on to supporting discharge with more volunteering as well, which is really great. And at last week's 4 boards meeting, we had the national lead of Helpforce talk to us about the great work that we're doing in the group on volunteering. So embedding prevention, so a lot of work going on in prevention, and whilst you can get into the complexities of individual specialties, secondary prevention, there's a big focus for us on avoiding those unnecessary admissions, particularly around some of our frail older patients, making sure that we don't bring them to hospital unless we need to. When they come to hospital, treating them in an ambulatory fashion, and if they need admission, getting them home as rapidly as possible. So all of that is helping to ensure that our demand is as manageable as it can be. Over lunchtime, I spent some time with the National Chief Finance Officer trying to understand what's going on with productivity in the NHS, and particularly the measurement of some of the different pathways that we have. For a lot of our urgent care now, we are managing patients virtually. We are giving advice to primary care. We are mobilising our teams to avoid even conveyance to hospital with our frailty team. So there's an awful lot of extra activity beyond the traditional A&E attendance, hospital admission in our urgent care workforce. So there's a number of these that are amber rated, which is we're halfway through the year. So I'm comfortable that we will be making some further progress, and ideally we'll be turning many of these to green. There's quite a few that are green, and you can see the work that's going on around prevention, around tobacco dependency work that's quoted there. We are also doing quite a bit of work to improve the use of data across the organisation, and we've been doing training on our Power BI tool. We've been looking at our key performance indicators and developing different dashboards on that. And we've started to use a population health tool across Coventry and Warwickshire. We're kind of leading on that in Coventry and Warwickshire, which will help to target some of our services, but also some of our prevention activity. I'm going to keep going as quickly as I can, and we also doing a lot on our other big move around reducing our carbon footprint, and you can see an update on that. We shared this with other parts of the group and learned about some of their actions in the meeting last week also. It is quite hard to model what's happening with energy prices. So as we switch to more electricity and less gas, in the short term, there's potentially a financial hit for that. In the longer term, there almost certainly won't be. So we're having to kind of get ahead of the curve, but that's got a bit of a financial kickback on it. Integrated care models, and was there anything else I wanted to draw out? The one thing I did want to draw out, because I know that you'd want me to talk about this, actually two things I'll say. We have been doing some work on our what we call our Excel in Everything program, which is trying to lead our improvement program to deliver efficiency as well as quality improvements. Adam talked last week at a National Association of Groups event about how that program is the way to do it, which I completely agree. In other organisations, there tends to be a almost parallel universe of cost improvement versus quality improvement. So it's been great to see how that's taking forward, and the national team are really interested in our approach. The other one I wanted to mention was the red rated issue, which is the implementation of the electronic patient record. The sequencing of this is that we will be moving to the same electronic patient record across Coventry and Warwickshire, or certainly that was the intention. UHCW are implementing that first, and they were due to be implementing that right now. Due to their readiness assessment, they have decided to defer their implementation to some point during 2024. So we are currently waiting to get clarification on what that timing is, and for us, just taking a bit of a stock take on whether following them and implementing exactly the same instance of that system is the right approach to us. We have potentially some other options, but understandably that's red rated as a consequence of those delays, and we will obviously be making some decisions and sharing that at board and at Council of Governors in the future. And some really impressive stats on trials and the work we're doing with Warwick Business School as well as Warwick Medical School. That's all I wanted to highlight. I probably went on too long, Chairman, but there is a lot going on despite all of those pressures.
No, great, thank you, Glenn. And some comments in the chat box. Just one question from me, and then we'll move on if governors can ask questions in the chat box as fast as possible. I'll come to you in a second, Kelly. What's worrying you most, Glenn?
So obviously the clocks went back. So we have winter, and it's going to be a tricky winter. And I suppose if you look at some of the wider pressures on society that could lead to, for example, more mental health admissions during this winter, more vulnerable people potentially needing our care. So those things worry me in the context of the workforce, and we talked about the strikes, but also the thing that we weren't able to talk about is a resolution to the strikes yet. So the prospects of more strikes over the winter period worry me very much. And I'm not going to get into the politics of all of this, but we need it to be settled. We not only need a settlement, but we need a legacy from that is a workforce that are feeling motivated and supported. And I worry about, even if we get a settlement, whether we will have some legacy issues that we will need to work on. Our relationships with all of our workforce are great locally, and we need to make sure that this doesn't get in the way of us all working together for the best of our patients.
Thank you, Glenn. One question from Callie, then we'll move on. Callie?
Right. I just want to ask what the Civility Saves Lives training is, what it is about. Civility Saves Lives. That's
great question. It's all about culture. It's all about culture in the workplace, but also if the workplace is a hospital, then if you have a bad culture, if you have egos, if you have hierarchy, if you don't have a situation where people can talk civilly to each other, where maybe in some cases people are being rude and aggressive towards each other, that has a safety impact. And so this is a piece of work that was developed by a consultant who originated at University Hospitals Coventry in Warwickshire, who's developed this program nationally. It's a really good program. We've done it as a board, as well as making sure that we immerse as many of our staff across the organisation, across the group in it. And so it's a safety initiative about people supporting each other.
Yeah, that's great. And just a very quick one. What is the care? There is a care collaborative matrix team. What is this care collaborative? Is it within? Is it across the patch, or is it within the trust? Care collaborative matrix team.
Yeah, it's a short question, but possibly a long answer. Maybe one we could provide a bit more information on. But put simply, the care collaborative is a framework through which we will hold the ring as lead provider for the whole of the Warwickshire contract. Ultimately, it starts with out of hospital services, so community services. So it takes on the community services contract that was traditionally a contract into an arrangement where we're the ongoing lead provider into the future, by delegating responsibilities from the integrated care system to us. And then in that role as lead provider, we will obviously need to work with all parties at place, with George Eliot around Warwickshire North, with UHCW around Rugby, to make sure that we deliver the best care within the resources that we have. But that's an important responsibility that's being placed on Swift.
Thanks, Callie. The care collaboratives have been around for a while, but happy to provide a further briefing to governors if that's what you would like. Just one thing from me is Shan's mentioned in the chat box about Samaritans going into the A&E. For members of the public who are watching this, there is nothing, I don't think, more wonderful than volunteering to come and help out at Swift. It is a wonderful sense of purpose. When I speak to our volunteers, I know a number of them, the sense of personal satisfaction they get from volunteering is enormous. And over the next year, we are going to do more and more working with our different volunteer organisations. Our governors are mainly volunteers. We have the Patient Forum, we have all of Sharon's work as well. But I would really encourage, if you're a member of society, maybe you've retired too young, you're looking for something purposeful to do, become a volunteer. It's wonderful. So with that, I'll move on to the clinical governance assurance report. David Spraggett, please.
Hi, yeah. I think I'll just take the report as read and invite any questions.
David, that's incredibly efficient of you.
I'll do my best to be efficient.
No, thank you. Are there any questions from governors on the clinical governance report?
Not now, yeah. Just try to find.
We make sure we're on mute, please, Callie. Are there any questions from governors, please, regarding the clinical governance report? Otherwise, I'll take it as read and save us some time. Just one from me then, David. What's worrying you most as chair of clinical governance?
I suppose it's actually the consequences of all the increased activity in the trust is inevitably going to make it even more difficult to keep clinical quality and standards as high as we'd like them to be. I mean, and I haven't seen any evidence yet that we've compromised, but as it seems to be escalating, not quite exponentially, but certainly incredibly, the chances of clinical errors occurring increase. I mean, that's even in the best run things. So I think we just have to be vigilant. I think one thing that I'm really pleased about is there seems to be still enthusiasm is probably the wrong term, but for any incident that is occurring on the wards is being reported high numbers, which when people are being really stressed, I think we should take that as a real positive. But yeah, I think it's the consequences of the increased activity which of course we can't do a great deal about because, as we all know, the door's open, isn't it?
Yeah. No, thank you, David. Callie, is that a legacy hand?
No. A very quick question. It says that the Council Services annual report was not submitted on this occasion. And I just wonder who does this report and why they were unable to, on this occasion, to submit a report, because Council Services is important part of.
Yeah, it's a good question because I don't actually know the answer. I think that the person that was going to be presenting it just couldn't be available for that particular meeting and will be presenting it at a future meeting. It isn't that the report isn't going to occur.
Yeah. No,
Is that someone from the trust, a clinician from the trust, or usually that presents it, or is it a senior manager?
Right.
Or?
Usually it is a clinician from the trust that actually presents it, yes. But they're always supported by one of the management team.
Yeah.
Okay, thank you.
Thank you, Callie. Okay, we'll move on then. This is turning out to be probably our most financially challenged year. Kim, brief us on the money then, please.
Thank you, Russell. So the year-to-date position, which is there for the first 6 months, we're reporting a deficit of £4.5 million against a plan for the full year of a break-even position. The key drivers really to that position is continued spend around agency, some of which is driven really by the industrial action. I think Harkamal mentioned really some sort of a figure that was quoted, but actually it's probably not a true reflection of the cost of the strike action, because not only is it about lost activity and additional costs to cover for people acting up, you've also got the cost of rescheduling activity as well. So we probably estimate that the costs has probably been around about £3 million actually that we estimate at the moment that's been incurred, and on top of that we have lost obviously the management headroom in terms of delivery against our cost improvement programme as well. So that's caused slippage, and that's impacted on our year-to-date position. However, despite that, we have made some real improvements in terms of our agency reduction. This is the second month in a row that we've seen spend on agency to below the £1 million mark, which actually, in the context of the operational pressures, is a significant improvement. And we've also effectively eliminated some agency spend on clinical support workers and also our high cost agency, which again is really positive and testament really to the operational and nursing teams who've been able to sort of manage that spend moving forward. The challenge is obviously moving forward in terms of the second half of the year around delivering on the plan itself. So that's what we're working with the divisions to actually do. The other bit to note, and this is really hot off the press, is that some of you may have read in the Health Service Journal. I wasn't sure if I saw it in the national news, but it's been, the government have announced that they're releasing about £800 million of support for strike action for the first half of the year to the NHS. Now, it sounds a massive figure, but actually, and unfortunately, the context of that is that already the NHS were reporting already that in terms of a year-to-date position of practically nearly double that in terms of a deficit. So it's not enough really to cover off the year-to-date national position. So what organisations have been asked to do is that that allocations worked its way down to the ICSs, and the ICSs are working with us to work out what is our share of that money to help us. And we're obviously internally trying to work out what else is the ask, because there's obviously conditions attached to that, and that will obviously have to go through our board for further discussion. So just a brief update, because that's a live hot off the press news. So I think that's all I wanted to highlight really to the governors today.
Thank you, Kim. Clearly a very challenging situation. Glenn, you were at a Chief Executives meeting yesterday. On that last point, is there anything you'd like to add to Kim's briefing?
No, as Kim said, it's the negotiations with the Treasury have been interesting, I think, nationally, in that the conclusion is that we can repurpose some of this existing NHS funding. So as Kim says, we just need to understand the implications of that. So other than the 200 million that was announced earlier in the year, there is no additional funding being given to the NHS, and there's an implication that we could reflect on the pace of recovery of the elective recovery programme nationally. I've been called to another call tomorrow to discuss the implications of that. So it's a bit of a moving feast at the moment.
Yeah. Okay, thank you, Glenn. Any questions to Kim? Otherwise, we'll move to the audit assurance report. Mike Lexman.
Yeah, Russell, just thinking about a conversation we had earlier at the pre-meet. Is there a risk in our capital programme if we end up making capital payments against the failed EPR at UHCW?
Glenn, do you want to handle that one?
Yeah, and it's a good question, because the way that capital works now is that the system is given a spending limit. So if any part of the system spends more than the plan, that potentially reduces the funding available to everyone else. So there is a discussion going on between UHCW and Cerner, the supplier, which will result in a cost to someone. We don't know what that is yet. The other thing we're not sure of yet, Mike, is whether that's going to impact on this financial year or whether it's next financial year. I think it's more likely to be next financial year, the way those discussions are going.
Okay, thanks.
Thank you, Glenn. And any other questions to Kim? Kim, I know it's a whole team challenge, but we're 4.5 million down after 6 months. So you go with all of our best wishes in terms of driving the performance to where we want it to be. I think we are now in our 13th year, Glenn will correct me, of being break even or better. So I know the whole team don't want this to be the year where we go below the water, but thank you all very much for your hard work. We'll move on then to the audit assurance report. Richard, what would you like to pull out?
I think I'll take the report as read. It's fairly coherent as a report in terms of going through everything. I would add again, thanks to Kim and her team, because we did actually achieve the sign off of the accounts by 30th of June, and which we didn't do last year, and the accounts were filed in Parliament by the 17th of July. We were one of the few trusts that achieved that. A lot of trusts didn't achieve that, so it was a big improvement year on year.
Okay, super. Thank you, Richard. Any questions or perspectives to Richard on the audit assurance report? Callie, you're on a roll today. Callie?
Yes, thank you. That's right. All I wanted to ask is regarding the contract management process, and there was a quarterly report, and there is a process, a policy in place. That policy, was made available to the board? Can we have a look at this contract management policy? And what contracts that covers? Is it all lengths, or and what services? Obviously, it's quite complex, but what contracts it covers?
Okay, so there's two parts to this, and Kim can clarify if I get anything wrong. But when I became chair of the audit committee, we were having various discussions about third-party contracts, and in the past, I think people have been saying that if we've got a third-party contract, there was a contract management in process and a contract management, but that didn't really reflect, to my view, the risks to the trusts. You know, are they financially viable? What happens if that supplier goes bust are we going to not pay the payroll or not be able to do cleaning or whatever? So that begat a lot of discussions, and at the same time it was decided that we would do more with the purchasing department to do a proper contract management, and that's been taken probably 6-8 months. And then when we get to the end of that, we're going to revisit all these third-party contracts. So it's been discussed at all the audit committees. So we've gone from a place where probably we were a bit exposed, and we are now working our way through and getting somewhere. We're not finally there yet, but I'm sure Kim will like to update us.
Right. This annual, the quarterly report is submitted to the board. Is that how it works?
Goes to the audit committee, and then they go to the board via the audit committee minutes.
Okay.
Kim, is there anything you'd like to add?
No, just to confirm with Richard, really, I think the policy just sets out the way that we rank, I suppose, the various contracts, because depending on the value or what the contract is there to supply, it has a degree of risk that we need to ensure ourselves is appropriately managed. And what we would do is actually put those into classifications, and as a result determine what level of support and oversight each of those contracts need, and also make it clear around how often we renew and review those contracts. So that's what the policy is setting out to do, but also the bit before it in terms of how we go about procuring to ensure that we get best value. So that's what it entails.
Thank you, Kim. And Mary?
Yeah, it's the same subject. I just wanted to check that when you're monitoring these third-party contracts, you're also monitoring the quality of the performance, not just financial performance.
Yeah, that's exactly why we felt we needed a policy to make sure that we've got all the right people involved in the contract monitoring to ensure that we assure ourselves not about just the financial aspects, but also any other KPIs that are required, and also the quality aspects as well.
Thank you.
And I think we're also looking at risk to the organisation, and we're also looking at length of contract, so that we've not got contracts that just been automatically rolled over because it's too difficult to find somebody to do it instead. So all those sort of risks are being reviewed.
Thank you, Richard. Thank you, Kim. Thank you, Mary. Thank you, Callie. I suggest we take a 5-minute loo break now, team, and we get back together in 5 minutes, and then we'll move on to the reports from representatives of governors on different projects and groups. So see you in 5 minutes. Thank you. Okay, ladies and gentlemen, if you can turn our cameras back on, just so I can make sure we're all there. So this is where we move on to the reports from representatives, governor representatives on projects and groups. You'll see from the list we go through the enormous amount of work the governor's put into ensuring that citizens' interests are input into the work of the trust. Some of these are reports, some of them are verbal updates, and in some cases meetings have been able to occur. But we'll start off with the Ellen Badger Hospital site redevelopment update. Mike Wells, over to you, please.
Thank you, Russell. So I'll take the report as read, and it's got some photos on there, which show some rapid progress that's been made recently. So we had a project board yesterday, and more good progress was being reported. So I'll just touch on a couple of things that may be of interest and aren't actually physically building related. The Trust have agreed to loan Shipston Museum 6 of the historical artefacts that will eventually be installed in the new hospital for use in an exhibition that starts when they reopen in the spring, so April 24. And then we'll have to liaise with them to get them back to be installed at the right time for the opening. And you'll see that I always write about the Stour Health and Wellbeing Partnership, which is the group that we fully expect to be leading on a lot of the health and wellbeing activities. They held, they held a healthy aging information event jointly hosted with the medical centre just at the end of October, and 19 different community groups supported the event, and there are over 90 attendees. We also had the Warwickshire County Council's dementia bus attend and was well used. And if anyone gets the opportunity to go on that, it's really quite disturbing, but gives you an incredible insight into what it would be like to have dementia. So it's really important for carers and stuff like that. And on the 29th of November, we've got a meeting with the Health and Wellbeing Hub. Sophie's coming to Shipston, and we're going to start talking about how we're going to make the hub work. We've already got a work stream on how it's actually going to look. And if I may, Russell, I will very quickly share a hot off the press no, what do I want to share? That. No, technology is too much for me.
Not the end of the world, Mike.
We'll give up on that. The floors have started to go in on the
Right.
on the hospital, so it's definitely making progress.
Okay, super. And we know, because we've talked about it before as a council, the challenges of the ICB's decision to go out to consultation, but that is what it is. We'll just conscious we've got an awful lot to cover. If there are any questions to Mike on the Ellen Badger Hospital plans, if we can pop them into the chat box, that would be great. Thank you, Mike. At the End of Life Committee update, Michael Coker.
Thank you. I have submitted a written report, which hopefully everybody's read. What I would say is this is a professional committee, and I'm just an observer. But I am impressed by the actions of that committee insofar as there is a distinct enthusiasm, it seems to me, to improve our methods. One of the difficulties I think we have to recognise, and perhaps other members on other committees might take note, is that obviously the main object of a hospital is people getting better. But obviously in a hospital, lots of people die. And the method by which, or at least the pathway they take at that time, is tremendously important, not only to them insofar as making them comfortable, but of course all the people related to them who feel that much better if their loved one is taken away gently and without problems. And the object of some of the things we talked about, as you see, is to embed into our procedures, professional procedures, things like SPIC, and for that to be just normal, and so in that respect I happily publicise that, because actually the majority of people don't like talking about death. I did nothing much else for about 20 years, and I suppose dealt with more deaths than most people have ever come across. But I'm very aware of the effect on everybody else, not only the person who died, but everybody else, and the method they, or at least the process they take in dying, is tremendously important.
Very, very well said, Michael. As you've heard me say in different forms, for me, the two most important things we do as a trust is to bring life safely into the world with our maternity services and to help life leave the world with dignity. We are very short of time on these updates, so if we can use the chat box as far as possible. But Callie, your hand is up again.
Yes, and I don't know, and there is a statement in your report about the obligation of relatives to register deaths within 5 days. I don't know where that came from, but the regulations currently, notification of deaths, regulations 2019, because I was involved in that, is that the relative or anyone else, or a friend of the deceased can register the death, but the medical examiner needs to also register the death. I just want to make this clarification, but I don't know why it's phrased like that, and again, that's it's the notification of death regulations that and they can refer it, they can ask to be referred to a coroner as well. They have the right to do so, but it's all in the regulations and is fully explained. But I don't know if it's imperative for the relative to register, but the death needs to be registered either by the relative or the hospital, but they have to do it because it's compulsory. So
major concern there actually was that that relatives, obviously knowing that they have a duty to do something, get very concerned if they're not able to do it, or in fact have the necessary information. And
yes,
it was
not everyone is aware of the regulations.
Yeah, well, it
the hospital needs to
hold on a minute, Callie.
Oh, sorry.
It was raised on that basis, and they're thinking about it, trying to help everybody so they don't get into that position.
Yeah, I think without sort of labouring the point, I mean, clearly when you lose a loved one at that type of time, you're going through an enormous amount of emotional stress. And even if you're told what to do, you quite often forget. And therefore us helping in that regard. Can I ask colleagues, please, to stay on mute? It's incredibly painful to the rest of us, the feedback. Thank you. Michael, thank you for your hard work on that very important area. David, I think on the falls prevention group, there's nothing to report. Is that correct?
That's correct. The previous one was cancelled at very short notice, and the next one is due next week. Okay. But however, I can assure colleagues that all falls are reported, thoroughly looked into, and necessary action taken. So I am confident with the group's effectiveness. Thank you.
Thank you very much, David. And again, if we can use the chat box as far as possible to make questions or perspectives, because we've got a lot to cover. Thank you. The patient experience group update, Carolyn?
Yes, hello. I'm just following up on Russell's talk about volunteers. I just want to briefly tell you, it's not in the report, at Stratford there are 45 volunteers and 16 applications, and they do all sorts of things, including minor injury, capillomas, cardiac rehab, Stratford League of Friends. Therapy dog will soon be going to Stratford, which is lovely, because in the rehab hospital, wherever that is, there are 58 volunteers, and including one-to-one activities, birthdays and help desk, and they have 3 dogs on
cat, and the McGregor ward nurse told me that once they had a racehorse coming to see the patient. So that's lovely. And at Warwick, there are 68 volunteers, 39 applications, and again, they do all sorts of things: activities, pharmacy, vaccine, rehab, bookshop, outpatients, etc., etc. And finally, I just want to plug the fundraising that they're talking about, which is half marathon next year, Victorian evening in Warwick Market, 23rd November, and a Hadrian's Wall walk on 6th June 24, and it's a knockout between Swift and GEH on the 7th of September 24. Good luck. I won't be doing any of that.
No, I can assure you, Glenn and I won't. You mentioning the fact that we have a number of pets as therapy. I'm actually giving an award to a dog in a couple of weeks as for its volunteer services. So I'm looking forward to that. Any questions or perspectives to Carolyn on the patient experience update?
I hope not, because I'm still new to this, so I may not be able to answer them. But
it's great, and I think, Carolyn, it's one of the things about being a volunteer as a governor, as a public governor, is you end up learning about stuff otherwise you wouldn't know. And it's really important to just again give the citizens perspectives on things as you become aware of them. So Kath is obviously a keen racehorse participant, albeit it's a racehorse rather than race house. So we'll move on then to the Patient Safety Surveillance Committee update. Sue?
Yes, I'll just take the paper as read, and all the governors know about, all the governors attended training this morning, know about PSIRF, the Patient Safety Instant Response Form, so I don't have to talk about that, thank goodness. No, sorry, I didn't mean that. Just to say that the committee continues to work around the implementation of PSIRF and how we take it forward within the trust, developing training and so forth, but I don't think I need to say any more than that at this moment.
Thank you. I mean, for members of the public, the move to PSIRF is to try and embed far more of a learning culture when there are incidents, so that the organisation can improve its level of safety and quality going forward. So it is quite a major change, but I'm sure will create, and it partly goes back to the civility saves lives question that Callie asked Glenn earlier, a whole culture of just being civil, being willing to be open, a freedom to speak up, and a sense of by doing that we'll learn more when and if we make mistakes. Unfortunately, mistakes do happen. It's how you learn from them. Any questions to Sue? So we'll move on then, thank you, to the patient portal focus group update. Pat? Pat, if you're speaking, I can't.
Sorry, we're still a bit slow taking himself off mute. Pat's not actually joined us today.
That's fine. So we take the report as read. It's probably worthwhile just for members of the public to be made aware that we have, I think, now 90,000 members of Warwickshire actually signed up to the patient portal. Adam, I was asked a question earlier, which I'll ask you because I'm like that, because I don't know the answer. Is there any way of embedding our patient portal more into the NHS app?
Yes, so we've done some of that. You can, our patient portal shares information with the NHS app. So at the moment, that's just in appointments. There are changes being made to the NHS app over the coming sort of 6 to 12 months that will allow us to share letters with the NHS app at the moment. The other thing you can do is use the same logon as is used for the NHS app to log into our patient portal.
Can you ever imagine a world where our patient portal is so totally subsumed within the NHS app?
I would love to imagine that world, Russell. So that was the original intention of the NHS app, that it was sort of a front door to individual organisational portals. I think there's been a little bit of backing off on that, but I do hope we're still heading in that direction.
We keep our fingers crossed. Any other questions on the patient portal? Okay, thank you. So we'll move on then to the Safer Discharge group. Jean, I think you're going to give a verbal update on this.
That's right. It was only yesterday, which is so I couldn't present the report to the group. So yesterday, the Safer Discharge Committee, just in case anybody doesn't know, is made up of a whole range of different members of staff, plus 2 governors, Mary and myself, and it's very wide-ranging in its discussions and meets bi-monthly. Some of the things that they're looking at the moment is criteria-led discharge. That is where the nurses prepare for discharge early during the week in preparation for when the patient is discharged. Quite a few wards are doing it, but not all wards yet, and we're encouraging, or the staff are encouraging them to take it on board, which is really good for patients because it's quite stressful if you've been told you can go home and you haven't got whatever you need for going home. The fact that we've got so many patients, which has already been discussed, coming through our doors and back out again, plus the pressure about criteria-led discharge, means there's great pressure on our pharmacy, and so they're coping admirably. Obviously, there are issues about how to try and continue to cope with such high numbers, but because of the committee, we're able to all work through it together. But what they are going to do is, because there are some things that need discussing in more detail, they're going to set up a separate little mini group rather than take up the time of the larger group, and that will feed back into the larger group, because obviously the people who attend are actually on duty running wards, and so it's really important that we make sure we use their time meaningfully. We're going to have a discharge event to celebrate our discharges and the amazing work that everybody does in order to increase the numbers that we have admitted and discharged, and so that is, really brilliant. It starts on the 27th of December, sorry, the 27th of November until the 1st of December, and they will try and include all wards and all parties. You'll see posters going up in the next few days advertising it. And one of our key partners will also be on the posters and included, and that's Warwickshire Fire Service, who are admirable at taking patients home at very short notice. That is the system to do that. And then when they get home, they go into the homes, make sure the patient's all right, and go again within 5 working days, and also report any issues to the place-based teams.
Jane, need to watch the time.
Yeah, sorry. And that's it, really. I was going to say that's it. Just to say that I once let a dog onto the ward for a patient who was pining for his dog and worrying about it, and I got told off for it, but it made such a difference to the patient that I didn't care. So I'm not changed.
I won't say good for you, but good for you. Just conscious of the time, questions and perspectives, Mary?
Just to add to what Gina said, there was a discussion there about the issues around respect forms not being issued adequately, and a long discussion about the ward pharmacy technicians and the support to discharge the project. But we discussed that quite a lot in our pre-meeting, so we won't say any more about that now, because that's been taken forward in different venues now.
Thank you. I'm conscious of time. Can I ask the question, Adam? I'm not sure if you know the answer.
Yeah, I did ask it in the chat anyway. If it's going to be a no, that's all.
Yeah. Sorry, Adam. Is there an audit on the compliance for criteria-led discharges? Do we know?
There was a recent trial.
Sorry, I'll ask Adam. Jane?
Yes.
Ask Adam, because it's an executive issue rather than a government issue. Adam, did you know the answer to that?
Yes, there has been. I don't think there's been a formal audit, but there has been some work on this. I can feed you back the work that's been done if it's helpful.
Okay, if we can just pop that into the minutes, and then we can answer it properly. But thank you. just making sure there's clarity, Jean, over who does the work and who helps make the work. So, Jean, thank you very much. Thank you, Jean and Mary, for your work on that, because safe discharges is a very important area. The wayfinding strategy group, I don't think we've got anything to report, Ruth, unless you're...
No, I'm going to save you time. There's nothing to report. We haven't had any meetings since the last AGM due to workload with the staff.
Okay, great. Thank you, Ruth. And then the elective care group update. Graham has sent his apologies. I believe that's correct, Sarah?
That's right, Russell, and he asked us to note the paper.
Yeah, but as you can see, a lovely new reception area and elective care hub is being built. So that is really exciting, I think, for next year. And again, as I've done previously, I want to apologise to members of the public for the very practical challenges of car parking and wayfinding at the moment on the site, but it will be worth it in the end. But if we don't go through this necessary pain, we won't have the great facilities we need to future-proof the trust. Anything you want to add to that, Adam?
No, nothing to add, Russell. Thank you.
Thank you, Adam. Then we've got the Salix project board. John, you're giving a verbal update on this, please. John, I can't hear you. I'm not sure if others can. Okay, I can't hear John. Can anyone else hear John? Okay, fine. We'll maybe come back to that later. The radiation project board sounds like something from a film called Oppenheimer. Carolyn, is there anything you'd like to update us on this?
Just very briefly, fortunately, saving you lots of time. This was my second meeting. I'm still unsure what's going on because it's very technical. I'm beginning to find my feet. So
did I get my? What was I turned off at that time?
Sorry, John, I'll come back to you in just a second. We just moved on to Carolyn because we couldn't hear you.
Yeah.
So I'll come back to you in a second, John. So the radiation project update, Carolyn?
Radiation Protection Committee, yes. EPR has been pulled indefinitely, as you probably know. There are too many risks at the moment, but although funding is available, it will continue through Lorenzo and change when UHCW does. 2 GPs will be guinea pigs. There have been significant improvements in pause and check radiation, which means that all staff are being extra vigilant and concentrating on getting all details of patients correct before any procedure. The age range for pregnancy checks was 10 years to 60. It's now 12 years to 60. More importantly, home reporting checks. Where there are monitors in homes that need checking, staff are indeed going out to check, and this is working well. Then there were reports from plain film, CT and MRI, cath lab and fluoroscopy, mammography and theatres. Generally speaking, dosimetry is normal. That's checking the staff are free from radiation. QA, quality assurance, is in date and compliant, and record of equipment is up to date. And finally, there will be a new recovery area open probably in the new year. And next time, which is February, I hope to have slightly more detail as I get my knowledge better of this committee.
No, that's great, Carolyn. Appreciate your hard work. Any questions to Carolyn on that? Thank you. So, John, just going back to the Salix report, apologies for the fact we couldn't hear you earlier, but any updates on the Salix report?
Not really. It's a very sensible project. I haven't been able to get into it deeply enough without going into the hospital and meeting everybody, but it looks a sensible project.
Okay, thank you, John. Adam, just in terms of the progress on Salix, just for a general update, when do we think that work will all be completed?
The work's going to commence in the new year, and it is spread over 2 financial years, so it will continue into next year. Just to note, we've just put in a bid for the next phase of Salix funding, which will further help decarbonise not only the Warwick site, but actually Stratford and Leamington as well. And that comes with a fairly significant amount of solar power as well. So unlike the current bid, it will reduce some of our ongoing costs, which will be really, really good news if we get that additional funding.
No, it's great. And I think, frankly, I'm immensely proud across the foundation group, actually, at the work being done at Wye Valley and George Eliot, and we'll get there with Worcestershire on this issue of carbon reduction, and the swift work with Salix is fantastic. So that would be great news. The Community Diagnostic Centre project update. Mike, anything you'd like to add to your report?
Well, I can say that the project seems to be going pretty well at the moment. The planning consent was excellent with no onerous conditions at all. But I need to update on the penultimate bullet point. I did say that the District Council were going to consider the list of community infrastructure levy grants this month. For a couple of reasons, they deferred consideration of it until the 4th of December to the next Cabinet meeting. And the business case from Jane Blackley is due to be presented to the Trust Board on the 6th of December. So it's a bit tight for understanding whether they approve our £1 million. There were two reasons they deferred consideration of the report. The first was that some of the councillors at the Overview and Scrutiny Committee spotted some mathematical errors in it. So they wanted those recalculated. And the chairman of the Overview and Scrutiny Committee, who's also on the Cabinet, said that he wanted assurances from us, from Swift, that the money would actually be spent if they gave it to us, based on the example of the money they gave us for Shipston, which is just sitting in one of our pockets somewhere. They were pretty snotty about all of that on Ellen Badger, and used it as a sort of a way to bash us. They sort of demanded assurance from us that we would spend the money on this Community Diagnostic Centre. And you feel as if you want to jump in and tell them all to stop talking nonsense, because once you start building the project in January, it will get built.
So I think, it's disappointing if that was the language that was used. Glenn, your perspective, please.
Yeah, I mean, it's obviously it's a little bit political in terms of the desire for us to put beds into Ellen Badger rather than the desire for us to treat more patients and see more patients in an ambulatory fashion. We need to do what's right for the local population in its entirety rather than just the local politicians.
Yeah, absolutely. I will try and put messages in through those councillors that I talk to, but I have to say some executives and myself are finding it extremely difficult to get any response from the nominated governor from Stratford District Council.
Okay, well, obviously this is a public meeting, Mike, so that will be duly recorded. Thank you. Any other questions? Otherwise, we'll move on to certain governance matters. Okay, thank you, Mike. If you could go back onto mute. Thank you for your hard work on that. So we've then got the minutes of the Patient Care Committee of the 11th of September and the draft minutes of the 9th of October. Anything you want to add to these, Jean or Andy?
Not from me, thank you very much, Russell.
It's Russell, can I jump in there? It was actually I chaired that meeting. I've been asked to feedback on that one because neither Andy or Jean could be there.
Okay.
So just very, very briefly, I mean, take the minutes as read. I just wanted to say that we did express some concerns about the Patient Care Committee receiving clinical governance reports some months after the date that they were written, but that's been reviewed and we're going to look at changes to that procedure, so that should resolve. We discussed the governor's concern log, and I just wanted to say to the governors, do remember that we do have this governor's concern log, so if you've got any concerns or compliments, please send them in to our administration officer, whoever the new one is going to be, and to Jean, to Andy, beg your pardon, to Andy, to put them onto the log for the next Patient Care Committee so that we can discuss any issues, particularly with David's there with us, and so we have some useful discussions there. But that was all from that, and I want to pull out from that meeting. Otherwise, take the minutes as read.
Thank you, Mary. Any questions from colleagues on the minutes? Okay, allowing minutes to duly sign those off in due course. The General Purposes Committee draft minutes of the 12th of October. Take those as read, Mary?
I think Andy was doing these. Oh, the general purposes. Sorry, there was another set of minutes for the patient care committee.
Yeah, we'd already done that, Mary.
Oh, well, I've done them both, have I? Okay.
So the general purposes committee, the draft minutes of the 12th of October.
Yeah, yeah.
Anything-
Again, take them as read again. But I think want to put a couple of things to stress for governors is that infection prevention and control training is a requirement for governors who want to visit wards and departments. And we've had very poor uptake in that training. So just to remind governors that they do need to take part in that. As you know, Mike will now be chairing this meeting. That will be my last general purposes, and Mike will be chairing. And I shall replace Russell as the vice chair for that committee. I'm talking about deputy chairs. It's now been agreed that if a deputy chair wants to attend any of the meetings that they're involved in, and in an observer capacity, they can do so provided the chair at the meeting agrees. It's so that there's some continuity if someone has to chair at short notice. The self-assessment process is going to be reviewed, and the form is going to be reviewed next year, so that will be on the agenda for coming months. And to a reminder for governors to send any issues that they would like training on into our administrator or now to Mike, so they can be put onto the training agenda. That's all. Thank you.
Thank you, Mary. Any questions on the General Purposes Committee draft minutes? Callie?
I just a reminder, I don't know about what meetings you're referring to, but all I was going to say is if we deputize for another governor in a group, it would be good to get the minutes and the agendas as deputies. I think we discussed that at the General Purposes Committee. I just can't remember if we agreed on that issue. That's all. Because I asked for it would be good if we get, as deputies, we get the minutes, even if we.
Yeah, I think if you're on a subcommittee, just ask the chair for those, Callan.
Okay.
Just ask.
Yes.
But I'm not sure who the chair is for a group. I mean, but anyway, I'll just liaise with the governor. That's okay. Who's
Well, if you ask Callie, we can let you know who the chairs are. I was really referring to people who chair our subcommittees.
Yes.
And chair other committees. But yes, if you're a deputy on a group, that on a working group, it may still be possible for you to attend as an observer. If as long as the chair at that meeting is agreeable.
Yeah, and I'm conscious of the fact that, you know, if we get too many people wanting to observe, it becomes problematic for a meeting. But we'll move on then to the report on resignation and appointment of governors. Thank you, Mary. Thank you, Callie. Sarah Collette.
Thank you, Russell. I'm happy to take this report as read. Thank you.
Any question on the resignation and appointment of governors? Callie, your hand's still up. I assume that's a legacy hand. Okay, we'll move on then to the annual self-assessment of the Council of Governors. Sarah?
Thank you, Russell. So this captures the 14 responses that we received from the governors. All of the comments are captured in the report. It's for the Council's consideration and to identify any actions arising, which will then be considered at the General Purposes Committee in January. Thank you.
Okay, thank you, Sarah. Any questions on the self-assessment? Callie, is that a legacy hand or do you want to ask a question?
No, it's a legacy hand.
Okay. Any questions on the self-assessment? There was some comments made in the self-assessment about the opportunities to input into strategy, I noticed, Sarah, but we do have the round tables, and I think I did remind governors that was the opportunity. I'd also encourage governors, even those maybe with less experience, to complete the self-assessment, because 14 isn't the full body of the governors that we have. And I'd also like to emphasise, particularly to stakeholder governors, you can't possibly represent your stakeholder if you don't attend governor meetings. And I'm conscious of the fact that we will need to watch going forwards the attendance of stakeholder governors at the various different meetings that we have. So I leave that in abeyance. Any other comments on the self-assessment? Mary? Mary, on mute.
Apologies. We do have governors who say they find it quite difficult to oversee the performance of the board and the NEDs. And I think I would stress that they should take up the opportunities that are available, because some of our sessions with our non-executives, for example, or even sessions with yourself, Russell, are not attended as well as we would have hoped. So I just encourage people to take up the opportunity that is provided.
Absolutely, Mary. I mean, I do have a session every month with governors, which NEDs join me at for all of the public governors. So that's a great opportunity. We do have a cycle of coffee meetings with NEDs again being set up, but it is for governors to make sure they take those opportunities. Otherwise, you won't get to know the NEDs. And there are the monthly board meetings. There are a very different forum, as Mary has indicated. Okay, we'll move on then to the Council of Governors and committee calendar of meetings for 24-25. This is for a decision. Sarah, thank you for putting this together with Sue. Any questions on those calendar of meetings, colleagues? If you're not happy to approve them, could you please raise a digital hand? So duly approved, thank you. The lead governor annual, sorry, I got all excited. The audit committee annual report. Richard, anything you'd like to add?
No, I wouldn't like to add anything to it. It's fairly self-explanatory. I think the only thing at the end, I did thank Kim, and who's now off the call, but I think the other thing is that I'd like to thank Sue Bunn as well, because for the first time she did a lot of the annual report, and it was done about a month, 6 weeks earlier, which made the whole process a lot easier. So going through that.
Thank you.
And also, I just note that Rosemary was at the start of the year the audit chair, and she left in December. So my thanks to her.
Thank you. Richard, any questions to Richard? Okay, thank you. So in my excitement, I was moving on to the lead governor annual report. Mary, anything you'd like to add to this? Thank you for putting it together.
No, just take it as read. If it's nothing to pull out, really. No, just hope I got it right.
No, you did. Any questions to Mary on the lead governor annual report? Okay, so we then move on to the appointment of lead. Mary, your hand went up on your own item.
Yeah, no, because I was coming back to the audit very, very quickly to remind governors that one governor can observe the audit committee. And so any governors who haven't yet taken up the opportunity, again, it's a chance of seeing how things are done. So do contact Sue Bunn and let her know if you'd like to attend an audit committee as an observer.
Yep, no, absolutely. And I'll give fulsome thanks to Mary in just a second. But Michael, your hand is up.
I was just going to say, I'm sure we all thank Mary for the work she's done over a long, long time. She has worked extremely hard and far more than most of us, and we appreciate it, Mary.
Yeah, and I was going to come on to that on the next item, Michael, but
sorry,
you're in like Flynn, the Errol Flynn of the Council of Governors, Michael Coker. But I'll allow Sarah to do the formal bit, and then I'll sort of build on that. So, Sarah, just in terms of the appointment of a new lead governor.
Thank you, Russell. So as the council's aware, the lead governor is appointed for 1 year. We've recently gone through the election process, and I'm recommending the appointment of Mike Wells as lead governor for 1 year until the 30th of November 24. So that's for the council to consider and approve, please. Thank you.
Michael, if I can ask you to take your hand down, I'll do it for you. If you're not happy to approve Mike Wells as our new lead governor, would you please raise a digital hand? Thank you, Mike, for volunteering. and given there are no raised hands, duly appointed. Just building on what Michael Coker said, Mary, you've been an outstanding lead governor. We've worked together now for, I think it's around 6 years, and I couldn't have asked for a more supportive lead governor. I don't think governors could have asked for a more committed lead governor. The amount of effort you put into the role is quite extraordinary. I've worked with 4 lead governors in different foundation trusts over the years, and you have been by far the most committed of all of them. And I'd like to put on public record mine and the board and all of the governors' thanks to you. You leave with our very best wishes. I know you will still be, if you like, a bit more behind the scenes, but very active within the trust. But thank you very much. And if you could thank your family as well for the sacrifices I know you have made when you've been willing to readjust your own personal plans to do the role. So thank you. You leave with our best wishes, Mary.
Thank you, Russell. Thank you all. I leave with a heavy heart, actually. I didn't really want to stand down, but it seemed to be time to do so. But I shall still be around. You haven't got rid of me.
Right, thank you.
Well done.
So moving then on to the reappointment of non-executive directors. Mary, I think you're standing in here for Roger.
Oh, yes, it's me again. Well, we had 2 NEDs which are approaching the end of their term of office in coming months. It was Yasmin Becker in February 24 and David Spraggart in April 24. So using the report from the NED's appraisal process, the Nomination and Remuneration Committee considered the reappointment of these 2 non-execs for a further 3-year period, and they'd like to recommend invite the Council of Governors to accept their recommendation of extending Yasmin Becker until February 27 and David Spraggart until April 27 to give them a 6-year term of office, which is within the NHSE governance guidelines.
Thank you very much, Mary. If you're not happy to approve those extensions, could you please raise a digital hand? Okay, duly approved. Yasmin and David, we're like the mafia. Once you're in, you can't escape. So thank you very much, and thank you very much for your hard work. Any other business, colleagues? Any further questions from governors? Please raise a digital hand. Any questions from members of the public?
We haven't got any present, Russell. Thank you.
So we'll therefore adjourn. I suggest we have another 5-minute comfort break and then get on to the confidential matters. For members of the public, when is our next Council of Governors meeting, please, Sarah?
It is the 15th of February at 2 o'clock.
Okay, great. Mary, your hand has now gone up.
Yes, I just feel I also want to say thank you to you, Russell, because I very much enjoyed my time as lead governor, and you've been very supportive, and I shall miss our monthly meetings. But thank you for everything that you've helped me as lead governor as well.
My pleasure, Mary. So we'll have a 5-minute comfort break, ladies and gentlemen, and then we'll reconvene and the new invite for confidential matters. And I wish members of the public who may watch this later a very happy Christmas when you get there. Take care, everyone. And when you're offered a COVID jab and a flu jab, please take up the opportunity. And if you've got a loved one in hospital, remember, home is best. Don't stay in hospital longer than you need to. Take care, everyone. See you in 5 minutes.